Cedo la palabra al doctor Roy Gulick, que nos hablará del resumen de los congresos de CROI y Elías de este año. Doctor Gulick.
Gracias, doctora Pérez, y buenas noches de mi oficina en Nueva York. Voy a compartir mis dispositivos. Ok. Reconocimos que hoy es el 1 de diciembre, el Día Mundial de SIDA, y reconocimos que hay mucho progreso con SIDA y VIH, pero necesitamos más. Y voy a cambiar a inglés ahora. To show the progress that we've made and what might be next, I'm pleased to update you on two recent meetings that occurred this year. The CROI meeting and the International AIDS meeting. Both of these meetings were changed to virtual meetings at the last minute. I have no disclosures. So I'm going to review for you the latest on HIV epidemiology, really focus on antiretroviral therapy, what's new in what to start, drug resistance, a new troubling side effect, weight gain, what's new in pregnancy, and then what new drugs are on the horizon. I'll then turn to prevention and briefly to cure, and then summarize guidelines for HIV in the time of COVID. Epidemiology. So every year at the International AIDS meeting, the UN AIDS releases the latest available data on the state of the AIDS epidemic worldwide. As you can see, the number of people by the end of 2019 who were living with HIV was 38 million. And as you can see in the graph, that is the highest number of people living with HIV since the beginning of the epidemic. That, of course, is good news. People living with HIV are not dying from their illness. However, even with all the progress, in 2019, 1.7 million people were newly infected with HIV. That number has been decreasing. You can see that the peak number of annual infections was in the late 1990s, when over 2.5 million people were newly affected per year. And you can see that number has been decreasing since that time, however, not likely to make the target that was set several years ago by the end of 2020. AIDS-related deaths fell to 690,000 in 2019, and you can see that this has been substantial progress in reduction of death since about the mid-2000s, where close to 2 million people died of AIDS, and now we see we're less than 700,000. And you can see that we may actually make the goal for 2020, depending on these data. Really interesting information about progress was released by the Australians in an abstract that was presented at CROI. This is looking at the concept of community viremia, that is how much uncontrolled HIV there is in a community, and what is that doing to HIV incidence. So this was from a cohort study done between 2012 and 2017, and it compared men who have sex with men, either with HIV, over 14,000, and a group of over 100,000 men without HIV. They used a number of sources for data, including sexual health clinics, general medical practice, community HIV testing sites, and 3 hospitals. And these were from New South Wales and Victoria, and represent about 60% of all Australians live in those two Australian states. From 2012 to 2017, as you can see in the graph, the number of people with detectable viremia in the community went from 29% down to 13%. That's the community as a whole. People living with HIV, the number with detectable viremia went from 17% in 2012 down to 4% in 2017. And you can see that's highly statistically significant. Undiagnosed HIV didn't really change. However, the community viral load, including all people living in the community, also decreased notably, 29% down to 13%. And then that equates to an HIV incidence rate of 0.88 back in 2012, falling to 0.22 by the end of 2017. What they concluded was decreased community viremia was strongly associated with a decrease in HIV incidence or new HIV cases. And some of this occurred before the widespread use of PrEP. So this is encouraging news to think that controlling HIV infection leads to a decrease in new infections. Also, very encouraging news came from the Kaiser insurance system, which is a big system of care in the United States. And they looked at a new estimate of life expectancy of people either living with or without HIV. They looked at a cohort of adults with HIV in care in this system over the years 2000 to 2016. And you can see they included a large number, 39,000. And then they matched them 1 to 10 with uninfected people who are also in care, just under 390,000. This study population was an average of 41 years old. It was diverse, including 5% Asians, 25% Black, 24% Latino or Latinx, and 45% white. And diverse risk groups: men who have sex with men, 70%, heterosexuals, 20%, injection drug users, 8%. And what did they find? Well, the life expectancy overall for the HIV negative group is shown in blue, and you can see that increased slightly from 2000 to 2016. But what was more remarkable was shown in orange, people with HIV. So what we're graphing here is expected years remaining at age 21. So back in 2000, life expectancy of about 60 years, but by the end of 26, that had increased to more than 70 years. And you can see the gap closes. What was more concerning was the look at comorbidity-free years. And you can see that the gap between HIV negative and HIV positive people didn't change over that time. What were these comorbidities? Well, common ones like cancer, diabetes, cardiovascular disease, liver, kidney, and lung disease. So although life expectancy improving, comorbidity-free life expectancy staying the same. Brenda reviewed this important study that was presented at the IAS meeting, looking at one of the largest descriptions of COVID-19 in people with and without HIV. And this is from the United States Veterans Administration cohort study. I won't repeat everything that the study showed since Brenda did review it, but I will tell you it's one of the largest studies yet, looking at about 30,000 people living with HIV and comparing them with 76,000 people not living with HIV and what happened with COVID. And as Brenda mentioned, people with HIV were tested more often for COVID-19 and had a slightly higher rate of positivity. But the good news was that there were no differences between HIV positive and HIV negative in terms of COVID ICU admissions, intubations, or deaths. And as Brenda mentioned, these kinds of data has been true for multiple cohort studies in both North America, including Canada, the US, and Mexico, as well as many European countries. One place in the world where there does appear to be a difference is in South Africa. And these are data from the Western Cape. They looked at a time period between March and June of this year. In this area of South Africa, which includes the large city of Cape Town, there are over 3.4 million adults living in that area. And 500,000 of them are living with HIV. About half of them are virologically suppressed on antiretrovirals. About a quarter are not confirmed suppressed on ART, and just under 20% never took antiretrovirals. They went back and looked at over 12,500 COVID-19 cases in the population, including 435 deaths. And they went back and looked at what factors were associated with death from COVID-19. And here's what they found. The risk of mortality is higher to the right of the line. Like other studies, they found that men had a higher rate of mortality than women. And I want to emphasize this is the entire population, both living with HIV and without HIV. They also found that older people had a higher risk of mortality, particularly over the age of 60 to 70. They found that diabetics had a higher rate of mortality, and those with hypertension, kidney disease. Surprisingly, they found that people with either prior or current tuberculosis had a higher rate of mortality from COVID. That had not previously been described. And most surprisingly, they found out that people living with HIV had a higher rate of mortality. Again, that's in contrast with most areas of the world. When they went back and looked, the hazard rate of death for the HIV positive people was over 2.5 times higher than HIV negative people. And that was regardless of whether they were taking ART or whether they were suppressed on ART. When they looked at it another way, they looked at people living with HIV in the population, shown in orange, by different years. So you can see the majority of people are age 20 to 60, with few people over the age of 60. But then they looked at people living with HIV in terms of mortality, and you can see there's a dissociation in COVID deaths in that it affected younger people living with HIV. And that's similar to what Brenda showed you in one of the other studies from the UK. Why is this? Well, an important caveat are the comorbidities, and that was not reported in this study. Back to HIV and antiretroviral therapy. What to start in 2020? Well, we saw a pooled analysis of 2 large studies featuring the integrase inhibitors, either bictegravir or dolutegravir, and importantly, looking at a population of people who are over the age of 50. As we all know, people living with HIV are increasing in age, and it is important to show that our regimens work as well in this population. So this abstract from Croy looked at 2 phase 3 studies in treatment-naive patients and compared the regimens of TAF, FTC, and bictegravir with a dolutegravir-based antiretroviral therapy regimen. That was combined either with abacavir 3TC or FTC and TAF. And the overall look was what proportion were less than 50 at the end of about 3 years. And here's what they found. So the good news was bictegravir, shown in blue, and dolutegravir, shown in red or orange, all did about the same. And you can see whether the person was greater than 50 or less than 50, over 80% of all patients suppressed below 50 copies at the end of 3 years. There was also comparable safety as well as efficacy to the overall population. And in people with detectable viral loads, they saw no resistance at all, no drug resistance in any treatment group. This study reinforces using integrase inhibitors first line. Now, Chuck Hicks looked at the issue of 2 versus 3 drug ART in his presentation. There was an interesting presentation at the IAS meeting that looked at inflammation in those 2 groups. This was a retrospective cohort study that took over 8,400 otherwise healthy people living with HIV who were suppressed on antivirals. And you can see most of them, 7,600, were on triple drug ART, but over 400 had changed to 2 drug ART, and over 300 to 1 drug ART, a strategy which we would not recommend today. What they looked at was the impact on inflammation in each of these groups. And this graph compares changes in different odds of having elevations in inflammatory markers, including D-dimers, C-reactive protein, interleukin-6, and other markers. And what you see here is that there was an increase in higher levels of both D-dimers and C-reactive protein in the group that switched to 2 drugs versus those who maintained on 3 drugs. Those are markers of inflammation. There were no differences in endpoints, clinical endpoints of death or end organ disease. But this is a provocative difference between 2 and 3 drugs. Where are we with drug resistance in 2020? Well, the trends in drug resistance here in the US show a decrease overall. And what you see here is a poster presented at the CROI meeting that came from over 84,000 samples that were submitted for routine HIV resistance testing over the time period of 2012 to 2018. About a third of all samples showed some degree of resistance. And so what they did in this analysis was to look at trends over time. Let's look at the graph. 2012 is shown in blue and 2018 is shown in orange. And you can see that the majority of resistance is 1-class resistance, but this has increased over time. Every other kind of resistance, 2, 3, or even 4-class resistance, has decreased over this same period of time, which is good news. Specifically, what about the classes? Well, resistance to non-nucleosides was consistent. It was the most frequently seen resistance on resistance testing in about 3/4 of people, regardless of which year was tested. However, resistance to the other classes decreased. So nuke resistance, nucleoside reverse transcriptase inhibitors, went from 55 to 41%. Protease inhibitor resistance decreased from 15 to 8%. Integrase inhibitor resistance decreased slightly from 20 to 17. And as mentioned, multi-class resistance decreased and 4-class resistance was quite rare. They acknowledged these trends and said that they were most likely due to improved and more convenient ART options. Well, what about side effects? An emerging side effect with antiretroviral therapy is weight gain. This is best shown in a study from South Africa called the ADVANCE study. This was a study of South African people living with HIV who were antiretroviral therapy naive and randomized to either the standard of care, TDF, FTC, and efavirenz, or one of two dolutegravir-based regimens, either TDF-FTC or TAF-FTC. There were about 350 people in each arm, so a large study. When they looked at viral suppression to less than 50 out to week 96, or about 2 years, similar trends in all three. 74% suppressed with efavirenz and about 78% with dolutegravir. Looking at resistance, they did see more reverse transcriptase inhibitor resistance in people that failed efavirenz. But the notable finding from this study was weight gain. So let's take a look here. What we're looking at is average weight change over the course of 3 years. Men are on top. You can see that all three groups, efavirenz shown in green, TDF dolutegravir in blue, and TAF dolutegravir in red, all three experienced weight gain, but the greatest weight gain was in the TAF dolutegravir arm, intermediate in the TDF dolutegravir arm, and lowest in the efavirenz arm. And look at the numbers, 7 kilograms of weight gain over the course of 3 years, which is the highest of the three regimens. When you look at women, the numbers are even higher. The trends are the same. TAF dolutegravir was associated with the highest weight gain, and in this group, over 12 kilograms of weight gain over 3 years. Intermediate with the TDF dolutegravir, and lowest with the efavirenz-based regimen. Well, what are the possible strategies for addressing weight gain with antiretrovirals? And as you can see, this has been most linked to the integrase inhibitors, particularly dolutegravir and bictegravir, as well as the nucleoside TAF. So the TANGO study, which Dr. Hicks referred to, looked at continuing a 3-drug regimen with TAF in suppressed people who were randomized 1-to-1 to continue 3 drugs or reduce to 2 drugs. That is, they stopped the TAF, and this was a large study. As you know, and as he showed, 2 drugs was non-inferior to 3 drugs in terms of virologic suppression. But what happened to weight? That was the focus of this IAS presentation, which has also since been published in Clinical Infectious Diseases. And if you look at changes in weight, what you see is change from baseline was no different in the 2 groups, either the group that dropped the TAF or the group that continued TAF. They looked at it by duration of prior TAF, no difference. And they even looked at the most extreme weight gain, that is, people who gain more than 10% of their weight, and saw no difference between the 2 groups. So although the study was not designed to look at this strategy, they concluded that changing to 2 drugs was not associated with weight loss by 48 weeks. What about changing from the other way from TDF to TAF? Well, that was the subject of a cohort called OPERA that analyzed over 6,900 people who were on ART with virologic suppression, switched from TDF to TAF, and then either maintained their 3rd drug, a non-nucleoside or a protease inhibitor, or switched to an integrase inhibitor. What we're looking at is the portion of the analysis showing what happened when they switched from an NNRTI or a protease inhibitor to an integrase inhibitor. And what you see here is, this is prior to the switch, this is the time of switch. You can see no matter what integrase inhibitor they switched to, they experienced weight gain. And that was the conclusion. Those who maintained or switched to an integrase inhibitor had a similar weight gain, changing from TDF to TAF. And then lastly, what about switching off of an integrase inhibitor, perhaps to a non-nucleoside? DOR is the abbreviation for doravirine, which is the newest of the non-nucleosides. It's co-formulated with 3TC and TDF. Again, this study was not designed to look at weight gain, but when this became an issue, they went back and looked at their data. This was a switch study, so people were on either a protease inhibitor, a non-nucleoside, or an integrase-based regimen, and then were randomized either to continue that regimen or switch to later to a doravirine, 3TC, or TDF regimen. And the design of the study was that they either switched right away or they switched later. And it was a large study, over 650 people. So this was the purpose of the study was to look to see if virologic suppression would occur. But then when they completed the study, they went back to look at weight as well. Here's what they found. So 70% of people experienced weight gain that was less than a kilogram. So although it was increased from baseline, it was relatively mild. But the immediate switch group and the delayed switch group showed very similar increases in weight change. So you can see overall there was an increase of about 1.5 kilograms. The group that stayed on their protease or non-nucleoside or integrase, switching to doravirine did not change that. Then the group that delayed their switch to later had very similar weight gains as well. So they concluded that patients on TAF and an integrase inhibitor at baseline did not lose weight by week 48 after the switch to TDF and doravirine. So what strategies do we have for people that are gaining weight on antiretrovirals? Well, back to the basics, diet and exercise. We have no proof that switching antiretrovirals actually does anything to the weight gain, but there are a number of studies in progress. What about pregnancy? Well, we're all aware of the link between dolutegravir and neural tube defects. This was described first in a study called SAPAMO, which was a study of birth defects of antiretrovirals in Botswana that was started in 2014. And it's good to remember the reason this study was started was actually to look at efavirenz and neural tube defects. They initially reported that there was an increased incidence of neural tube defects with dolutegravir if that drug was taken at the time of conception. And the rate was about 0.3%. But what we saw at the IAS meeting was an update of these data. And what they did was to extend their data out to April of 2020. And this, they thought, accounted for about 70% of live births in Botswana. And what you see here is that the rate of neural tube defects actually fell from 0.3 to 0.19%. Well, how does that compare with other groups? The group that took no dolutegravir at conception had a 0.11 risk of neural tube defect. The group that took dolutegravir not at conception but during pregnancy was 0.04. And the control group of HIV negative women not taking antivirals was 0.07. So you see that these numbers are in range with one another, although this one, dolutegravir at conception, is numerically higher. It's not a lot larger, and all these numbers are quite low. They concluded that this rate of 0.19 would account for one excess neural tube defect per 1,000 treated during conception. And these updated results really led the WHO to now suggest that dolutegravir is the preferred antiretroviral in pregnancy. Another important study was called VESTED, and this was sponsored by the IMPACT Network. This was a large study of ART-naive pregnant women living with HIV who were 14 to 28 weeks gestation from 9 countries, most of them in Africa. They were randomized to dolutegravir TAF-FTC, shown in brown, dolutegravir TDF-FTC, shown in green, or an efavirenz-based regimen. And they looked at the results. Viral load less than 200 at delivery was high in both groups, but numerically and statistically better with dolutegravir. So 97.5% of the dolutegravir group were suppressed versus 91% in the efavirenz group. So they concluded dolutegravir was superior to efavirenz in pregnancy. They did describe 2 babies who were born with HIV, both on dolutegravir regimens, one of whom of the mothers had a detectable viral load, the other didn't. And then most importantly, perhaps, they looked at adverse outcomes during the study in these pregnant women. And they found that the TAF arm only had 24% adverse outcomes, which included things like preterm delivery and small for gestational age. The number in the other groups was higher at 33%. This is important because this study now gives us data on TAF in pregnancy, which we've not had before, which suggests that it is not associated with an increased risk of ill effects. Well, what about new drugs? Conferences are always full of new drug information, and this year was no exception. So fostemsavir is a small molecule that binds to GP120 and prevents HIV from attaching to the CD4 cell. That defines a new ART class known as a CD4 attachment inhibitor. This drug, based on the result of the study I'll show you, was approved by the US FDA. So the study that led to the approval was called BRIGHT, and this enrolled a unique class of people, heavily treatment experienced people living with HIV. So they had experienced multiple failures on prior regimens. Just under 300 had 1 to 2 remaining ART classes, and they were randomized to fostemsavir at a dose of 600 twice a day or a matching placebo. And then a separate group were the most treatment advanced, 99 with no remaining options, and they were not randomized, but all received fostemsavir. And here's the results. We're looking at the proportion of people who suppressed to less than 40. I should tell you that after a week of the randomization, they were allowed to optimize their background therapy. So you can see the randomized cohort, over 50% of people were able to regain virologic suppression, and that held steady for 2 years. And even in the green group here, who were the most treatment advanced, they also responded to fostemsavir with about 35% of people able to resuppress virologically. Based on these data, the US FDA approved fostemsavir for adults living with HIV who have tried multiple meds and whose infection cannot successfully be treated with other therapies because of resistance, intolerance, or safety considerations. So this is an oral medication that is now available in the United States. Well, another exciting new drug is an injectable integrase inhibitor called cabotegravir, also known as CAB. And these are the results that were presented at CROI from the Atlas 2M study. This was a large phase 3 open label non-inferiority study of over 1,000 people. And they took people who were either on standard of care oral antiretrovirals or were on prior studies with an all-injectable regimen of cabotegravir and rilpivirine, LA standing for long-acting. And all of these patients were suppressed. The study treatment was to compare giving the injectable regimen every 4 weeks, as had been done in prior studies, or give it every 8 weeks, which would obviously be more convenient for people. Well, how did it do? The good news was no difference in virologic suppression at week 48. Every 4 weeks is shown in blue, every 8 weeks in orange. You can see 94% of all patients on the study suppressed their viral load to less than 50. Very few had detectable viral loads. Safety injection site reactions were quite common, but often mild and only lasted about 3 days on average. They concluded that giving the all-injectable regimen every other month, that is Q8 weeks, was non-inferior to every 4 weeks. You may know that injectable cabotegravir has been approved in Canada and is being under consideration at the Food and Drug Administration in the United States for approval. And be interesting to see if it makes it by the end of this year, but certainly these data are supportive. Well, a brand new drug with a new mechanism of action is called lenacapavir. This is the first in a class called capsid inhibitors. So if you recall the life cycle of HIV, the capsid is the structure that encapsulates or provides a shield to the viral RNA. And so the capsid inhibitor both prevents formation of the capsid and also disintegration of the capsid. This new drug is highly potent against HIV in the test tube, active against all subtypes, and most importantly, has decreased clearance and solubility that leads to a very long half-life of 30 to 43 days. This would support very infrequent dosing of this new kind of HIV drug. Also of interest, it's being developed both with oral and subcutaneous formulations. So another potentially injectable antiviral. The phase 1 data we saw before and was published in Nature this summer and showed that at the highest doses tested, this was a very potent agent in people, which was linked to a 2 log drop in viral loads over the course of 9 days, which certainly is a potent drug. It also has a new sustained delivery formulation that we heard about at the IAS meeting. And what we're looking at here is 3 different dosing schedules for lenacapavir. The horizontal line here is target doses. And so you can see 2 of these dosing schedules led to prolonged therapeutic or potentially therapeutic doses of this drug for as long as 6 months. So getting a subcutaneous dose of this new sustained delivery formulation led to potentially antiviral effects over 6 months. Could this lead to an all-injectable regimen that would only have to be given twice a year? Well, studies are in progress. Another new drug is islatravir. This is a NRTTI, nucleoside reverse transcriptase translocation inhibitor. It's an adenosine analog and has activity in the test tube against NRTI-resistant viruses. The half-life of the drug is also long, 50 to 60 hours, and it is available both in oral and parenteral formulations. It's been studied as part of a triple combination with doravirine and 3TC, and we saw these results from the phase 2 study that virologic suppression rates were good for triple combination and then dropping the 3TC to a double combination. Phase 3 is in progress right now in treatment naive, switch patients, and treatment experienced. Lastly, prevention. Probably the biggest news at the IAS meeting was that HIV Prevention Trials Network 083 study. This was looking at PrEP with an injectable drug, that same drug, intramuscular cabotegravir, and compared it with 1 pill once a day, TDF FTC, standard PrEP. It was a large study of over 4,500 men who have sex with men and transgender women, and they were randomized to get IM cabotegravir every other month versus taking one pill once a day, TDF-FTC. It was double-blinded, so all people got injections and all people got pills. This study was stopped early because of a difference between the groups. And what's graphed for you here are new HIV infections. You can see numerically there were more in the TDF-FTC group than the cabotegravir group. In fact, 13 with CAB versus 3 times as many, 39 with TDF-FTC. Incident rates were similar, lower in the CAB group, and relatively well tolerated, with injection site reactions being the most common. They concluded CAB was not only non-inferior, but superior, and these data are at the FDA right now. And then another study came out just recently, just last month, from the HPTN. It was a parallel study of IM-CAB versus TDF-FTC, but this time in women in sub-Saharan Africa. So over 3,200 women participated. They were randomized. Everyone got injections and pills, and the DSMB stopped the study early. Similar results to the prior study. Fewer infections with the injectable CAB, 4 versus 34 with the oral pills, and that is statistically significantly better. So they concluded, once again, cabotegravir superior for PrEP in women in sub-Saharan Africa. Well, the Discover study was one we followed before, looking at TAF-FTC versus TDF-FTC, and we've seen these results before, but they were extended out now to 96 weeks and show similar degrees of efficacy between these two preparations. As you may know, TAF-FTC was approved by the FDA earlier this year for PrEP. They went back and looked at weight, and there was more weight gain in the TAF group in these HIV negative people than the TDF group, as shown for you here. One disappointing result on prevention was presented at the CROI meeting. This was the HIV Vaccine Trials Network, the HVTN, testing a vaccine that was related to the Thai vaccine that had shown some efficacy in Thailand previously. However, when they looked at this phase 2b/3 study of this HIV vaccine, Alvac with GP120 and MF59, over 5,400 people, they could see no difference in acquiring HIV, either in women, shown in blue and orange, the vaccine in orange, the placebo in blue, or in men, vaccine shown in gray and placebo shown in gray and vaccine shown in yellow. So no efficacy, and this study was stopped early by the DSMB. Lastly, about cure, there was a patient called the Sao Paulo patient who was a study from Brazil looking at 30 patients on first-line ART and with CD4s above 350 and virologic suppression. They added to their regimen dolutegravir, maraviroc, and nicotinamide. What were they trying to do? Well, nicotinamide inhibits HDAC, one of the enzymes that controls latency of HIV, and so they were looking for cellular latency reversal. Maraviroc can induce HIV transcription, so they use these two together to try to activate cells. How'd they do? Well, they did see in one patient that they could definitely, they'd been suppressed, definitely show an activation with this change. What was interesting afterwards is they eventually stopped antivirals, and this one patient maintained an undetectable level. What does that mean? Well, none of the other 29 patients showed a similar pattern, but this may be an example of post-ART treatment control. I'm not going to go into the HIV COVID guidelines because Brenda did already. So let me switch you and just tell you this, lastly, that the COVID-19 NIH treatment guidelines are a good source. I'm proud to be one of the 3 co-chairs of this, as you heard earlier, and I would refer you to these guidelines for the latest treatment information on COVID. So I want to thank some friends for loaning me some slides. And just as a preview of upcoming conferences, CROI supposed to be held in March in Chicago, and IAS supposed to be held in Berlin in July, and of course, time will tell. Muchas gracias por su atención.